Hello, my name's Scarlett McNally and I've now recorded the educational session that I tried to do as a hybrid training session for some of the doctor's assistants in Eastbourne and some online, and I'm sorry it went very badly and sometimes things don't go right. So here we are. Hopefully you can settle down and just watch this without all those distractions, and thank you very much for everyone who tried to help with the technical side. So my name is Scarlett McNally and I've been a doctor for 32 years and I've been a consultant orthopaedic surgeon at Eastbourne for 20 years. And I'm really pleased with the Doctor's Assistant programme and how you guys, how hard you work. And so what I've tried to do, because we've got new people joining and then some people who've been with us for 5 years already. So I've picked the best slides out of the other talks we've had over the last couple of years, just to sow some seeds really. So apologies if it's huge amounts of information, but it's really trying to get you to think in a slightly different way, and also to talk about the apprenticeship, because I think that is a really good way of being able to challenge things yourself. So doctors work differently from how people think. Actually, bodies normally sort themselves out. Most fractures heal up on their own. All orthopaedic surgeons do is put them in the right place, for example. So what we're trying to do is to find things that have to be fixed, or things for which drugs can be helpful. Sometimes just making a diagnosis is enough. Just being clear to someone how it's going to develop over time is helpful, and it doesn't need to be fixed. And just bear in mind there's the risk of the disease and then the risk of the treatments, and sometimes, particularly with an aging population with multiple comorbidities, sometimes the treatment's worse than the disease. What we're trying to push at another place I work half a day a week for the Centre for Perioperative Care is talking about shared decision making. So with patients, talking about the benefits, the risks, benefits, alternatives, and what if we do nothing, and we call that BRAN, risks, benefits, alternatives, and what if we do nothing. Because for some people, in their own mind, they know they'd be better just getting on with their lives rather than having a treatment if they couldn't cope with the complications, for example. Quick overview about how bodies work. The big thing is nutrition, that we don't really even teach that at medical school, or we do a bit, but it's the fuel and it's all the minerals and ways of getting the enzymes and so forth working properly. The immune system protects you from infection and also clears up cancers, and we're probably forming cancers all the time, but our immune system gets rid of them. The liver is there to process proteins and other materials and to make some things. Kidneys get rid of excess stuff. That's really useful, minerals and other things. Hormones are tiny molecules that circulate in the bloodstream. They're very similar to neurotransmitters at the end of nerves, and they basically tell the body what to do. And at the nervous system, you've got the central nervous system, the brain, and then peripheral nervous system, which is all the nerves, and then the autonomic ones that you kind of can't feel happening, that deal with your gut and smooth muscle and just normal processes going on. So that's basically how bodies work. And how do we manage patients? Doctors are kind of trained to do things very methodically in order not to miss something, because sometimes unless you ask, you don't get the answer to the question that can help make the diagnosis. You all know this, I'm sorry, we're going back over old ground. So it's a sequence of history, examination, investigations, diagnosis and plan. And in the history, there are certain questions one should ask in order to try and get all the information about what they've had done before, other things. And in the examination, you go through in a certain order in order not to miss things. So you're examining the problem, but also heart and lungs and other things. So, and you guys have to interpret the scribblings. So that's saying lungs are clear, or lungs have a little bit of fluid in the bottom, or and that the shape is an abdomen, and has it got a mass in it, or something where it is. And SNT, soft non-tender. So you're having to interpret these things, and different doctors, there are 34 medical schools in the UK, and each of them has a different way of teaching. A bit about the discharge summaries. I've borrowed this slide from Dr. Connor Fee, who very kindly taught, so I'll leave that up just for a second. And as you'll realise, there are different abbreviations in different specialties. So PID is prolapsed intervertebral disc in orthopaedics, or it's pelvic inflammatory disease in gynecology, and ED is the emergency department, but it's also eating disorder or erectile dysfunction, which I think is one reason some people still call it A&E. Just saying. And the clinical summary, this is the discharge summary, is kind of what do we do, but actually the most important thing that I feel the primary care want to know is what's the patient being told, what's expected, and what's going to happen next. So they really are keen to know if there's a follow-up appointment being arranged, or if there's something that someone's expecting them to follow up, and in which case it needs to be clearly spelled out. They're getting huge volume of communication every day. And this is just again another slide. So for example, on the anticoagulation, if the patient's been newly started on anticoagulation, does it need following up? How long is it going to be there for? And it might be warfarin that needs very regular monitoring, or one of the direct oral anticoagulants that don't need so much monitoring, or an injection. This is about acute kidney injury, so that's another box on the discharge summary. So basically there are grades. Has the creatinine gone up a little bit, a moderate size, or a lot? So the numbers you want to remember are 2 and 3, and obviously most people won't have acute kidney injury. And this is the respect form that we've borrowed that kindly from I think Berkshire Hospital, and it's basically, this again is a communication thing about what does the patient want if they had something go wrong and weren't able to make an instant decision. What's their long-term life beliefs, and that's quite important. And now clinical coding. And the clinical coders go through every set of notes to determine what actually happened and put codes on it. But they aren't allowed to guess. They can only put onto the numbered record what was written in the notes. So they can't, they can, if someone's got BMI of over 30, they can log that, but they actually, they need to see obesity or things rather than query or it not being put down, because the way that the hospital's funded is dealing with more complex patients, you actually get more funding, and also if something goes wrong, it's not that the hospital's made a mistake, it's that the patient had many other things going wrong, and therefore the risk of something going wrong was greater. So the coders can't code what they can't see, so we actually need to put diagnoses whenever we can. So on a ward round, ask someone, is the diagnosis chest infection, is the diagnosis pneumonia, just so it's clearly written down. And this is kind of how it helps the hospital. So the difference in coding numbers between whether they've got an unspecified infection or a lobar pneumonia, for example, with all the other things, adds on a little bit of say extra funding, but also reality of what should happen. So just be aware, every good diagnosis can be coded. A little bit about hip fractures, because they're very common, about 80,000 a year in the UK. So people fall, a lot of them are preventable. It's kind of weak bones and so forth. Unfortunately, on one side you've got the screws for the dynamic hip screw, and on the other side you've got a hemi-arthroplasty representing half the hip, and the difference is depending on where the fracture is. It's about 45% of one and 55% of the other. So sorry, gory slide alert. I saved this one from a hemiarthroplasty that was being done because this was just on the cusp of where the fracture was, and any that occur further down the leg actually manage to keep a blood supply going to the femoral head, the round bit, and therefore they can be treated with a plate and screws, a dynamic hip screw. But the ones that are nearer the head, so you basically just get like a tennis ball, that one isn't going to pick up a blood supply, so it's a replacement. So that's how one makes that decision. But the treatment's pretty much the same, apart from in the actual operation. In the operation we have X-rays when we're putting in plates and screws to get them in the right place, make sure they're not in the joint. But basically the treatment's the same, and these are slides from when we've tried to bring in fast tracking, because people need the same treatment. They need, everybody's a bit dehydrated if they've fallen and they've lost blood into their thigh and they haven't been able to get up and have a drink. Everybody needs a drip. So we wanted the drip to be started in the emergency department. We wanted the nurses to be empowered to get the correct blood test like group and save that would help them for their operation that would be required, and an ECG and looked at so that they're ready, and the anaesthetist doesn't come the next day and find they're in fast atrial fibrillation or something. So there's a little menu of things that are required as soon as possible to help the future. And it seems like you're depersonalizing by doing it in a package, but actually that's what the patient needs, and then you individualize it to the individual person. And what's needed is to get them from the emergency department to the ward, and hopefully a cup of tea if it's out of hours and they're not going to get an operation, and then the operation the next day. So we produced these forms about, and this was before integrated care pathways came in, but it was like, these are the kind of things you can do in advance to make it so much easier. And you can tell it's an old slide. That was when we were trying to bring it in, because those are my kids, and the little baby there has just gone to university, so I'm very proud. That's a slide I slip into any talks I possibly can. Moving on, we had a lovely talk about blood tests, and the critical thing is blood is a mixture. If you leave it to settle, you get the blood cells on the bottom, that's about 45%, and the plasma, which is kind of liquid, straw coloured liquid, all bloody fluids, all coloured liquid, on the top, and that's got the minerals and the all the stuff being transported. And you can think about the functions of blood. There's the red blood cells do transporting oxygen from the lungs to everywhere else. The blood transports hormones, nutrients, it regulates body temperature, protects the body from infection, which is the white blood cells, and it clots to prevent blood loss at sites of injury, and that's the platelets. So I'm sorry if I've oversimplified, but that's kind of it. And those blood cells we talked about are produced within red bone marrow. That's in the spine and the tops of your femurs and your thighs and your pelvis. They produce red blood cells and white blood cells and platelets. And there are different sorts, so if someone has got a urine infection, their neutrophil count goes up because your body produces more white blood cells of that sort to tackle that sort of infection. And I believe eosinophils, or if you've got worm infection, you get more eosinophils. So that's what that's one's looking for in the blood test. So there's a nice picture: platelets, red blood cells, white blood cells. So that's the full blood count. And then there's the other stuff in the blood, the kind of liquid component or plasma, and that's also called serum, S-E-R-U-M, serum. So we've got the full blood count, and then we've got the other stuff, which is sometimes called urea electrolytes, or renal tests, or electrolytes. And basically you're looking to see if one of the numbers is too high or too low. And the kidneys are what regulates so that you have a different amount up and down, and the liver processes things as well and packages things up into smaller molecules so they can be excreted by the kidneys. So plasma, as I said, is electrolytes like minerals like sodium, potassium, and it also includes protein. And there are some other tests, such as thyroid function tests. So that's measuring the hormone, thyroid hormone, and because it's quite common to have low thyroid hormone. So there you're looking for the actual level of the hormone, the T3 or T4, that actually does the work. But you're also looking for the thyroid stimulating hormone, because you want to see if that's really high, that your body's trying to make more thyroid hormone, or really low because it's been blocked by this kind of a feedback loop. So those bits are in the test. And it's similar with iron studies, that you don't just look for the level of iron, you look for a total iron binding capacity and things like that, just to try and get the whole picture, not just a snapshot. Another very common blood test is the coagulation screen. That's how well your blood clots. So the one to remember, really, you've got prothrombin time, you've got various things that try and work out what sort of clotting disorder there is. But the one I want to tell you about is INR, International Normalized Ratio. So a normal person's blood will clot in about, say, 10 minutes. And so the lab actually borrows some blood from someone else. They had a blood test for something else, and they see how long it takes. Say it takes 10 minutes to clot. And then they take the patient's blood, and they see that that takes 20 minutes to clot. And then the international normalized ratio is 2, or 2.0. So it's a ratio compared to something normal. So you're looking for a number, and if somebody's on blood thinners to try and prevent them having something that would cause a blood clot, they want the INR to be between 2 and 3, or between 2 and 3.5, or whatever it is. It will be set, and they take more or less warfarin to thin the blood in order to achieve that. So that's coagulation screen. C-reactive protein is another blood test one can do to test for inflammation. Now onto common medical problems. This is about acute kidney injury. I've just picked the nice slides, really. I'm grateful to people for their work giving these talks. So there might be a pre-renal problem. There might be something that is like drugs that are causing the kidneys not to work, or something like that, or dehydration, so the kidneys aren't getting enough fluid. I'm so sorry, drugs should be in the renal part. So pre-renal is not getting enough stuff going to the kidneys. Renal is a problem within the kidney, and post-renal is if you've got a blockage. So bear in mind you've got 2 kidneys. If you've got a problem, if you've got a problem, say with your prostate, that's causing a huge big bladder and backfill on both kidneys, that can damage them. If you've only got 1 kidney, you're much more susceptible. It becomes much more of an emergency to try and relieve any pressure on it if you've got, say, a kidney stone at the bottom of the ureter going down to the bladder, for example. So you need to work out, people need to work out where the problem is, and often scans and so forth are helpful with that. It's a lovely picture of the heart, and basically you've got, with the blood pressure, you've got the higher number and the lower number, and it's because the big pressure is squeezing out from the heart, and then when it relaxes, you've got the other vessels, so you get the systolic and diastolic pressure readings, so it never goes down to 0 in the arteries, and it's carrying oxygenated blood from the heart to the lungs, and then back to the heart, the left side of the heart, which is much bigger and pumps it around the body. The oxygenated blood goes around the body. And heart failure is when you've got a problem with the way the heart's pumping. So that's often caused by, it's actually quite rare to be problems with the heart valves these days, but caused by blood pressure. A heart attack is constriction or problem with the tiny little vessels that go to the heart muscle itself. A cardiomyopathy, problem with the heart muscle. Arrhythmias, because you have you're supposed to have a normal rhythm, but if it goes fibrillating or something, it can cause a problem. Obviously it's not pumping efficiently, not getting all the muscles to contract in the same time. Or if you've got conditions increasing the demand for oxygen, such as anemia, you've got a low hemoglobin, and therefore your heart's having to pump really, really hard and can't quite manage it. And with heart failure, they're short of breath. They've got often there's pitting edema, because not only can the heart not pump the fluid on, but it's kind of, there's a back pressure, so you get swollen legs, and when you squeeze, you get a little pit. And now a little bit about the electrical activity in the heart, because you all can do ECGs, and there's a node that's kind of spontaneously, they're funny little cells, they just put out an electric impulse regularly, and that goes in a certain pattern around the heart, and so it causes the atria that receive to squeeze just before the ventricles, so everything squeezes into the ventricles, and the ventricles do a big squeeze, and it's supposed to be at the same time, but as some people have a problem, and some people then need a pacemaker, and the problem with atrial fibrillation is if it's wobbling so much, you're getting blood not pumped on efficiently, you might get blood clots that then might go up to the brain and cause a stroke. So that's why people on atrial fibrillation get the anticoagulants. Like that. So here's a normal ECG, and it's basically a record of that a pulse wave going through, and it goes PQRST, and you're looking for those being nice things and regular, and there's in that bit between S and T, if it goes down or if it goes up, there may be a problem with the amount of oxygen that the heart muscle itself is getting. So we're worried with the particularly ST elevation can be a sign of a heart attack at that time. That's one thing to look out for. And then you can get T waves instead of going up, going down, and that's another thing. So it's just a kind of sometimes you just need a few little things to be aware of, and you know, if someone's got atrial fibrillation, you might not get P waves, because the P wave is the atrium contracting first, and the QRS, obviously, it's a big spike of electricity. That's the ventricle. Moving straight on to stroke, that's blood supply to the brain, and it's either a blockage. Ischemia means not enough oxygen. It's either a blockage or it's a bleed. So obviously you don't want to treat a bleeding sort of one, which is less common, as if it's a blockage. So you need to find out which sort it is, usually with a scan. And obviously with strokes, I think it's done very well with the kind of education of the public about FAST, face, arm, speech, time, thinking this might be a stroke because the arm isn't working, the face is hanging down. And when you're examining, or when the doctors are examining, it's power, the weakness, sensation is kind of numbness, and the speech being slurred or not normal, or not being able to understand it if it's that part of the brain, because different parts of the brain are affected. And the immediate management of stroke, there is a possibility of giving thrombolysis, so clot busting drugs. Sometimes people can actually operate on the carotid in here to take out any blockage that might be about to cause a stroke. But with the thrombolysis, there's only a limited amount of time that it's useful for, and it's only, as I said, for the ones about clot or reducing oxygen supply rather than a bleed. And on the stroke ward itself, there are many more tests, and it's much more specialised. And the particular problem is, can the person swallow? Because obviously you don't want the food to going down into their lungs if they can't swallow correctly. Now, we had a lovely talk from pharmacy, and I'll send that round separately and with a link that they also sent. So these are just my favourite slides from that talk. So there are lots of sound-alike drug names. So this is why doctors' assistants do not have a role in prescribing or administering or transcribing or anything about drugs, because in fact there is a risk. About 10% of drug charts have an error on them, or 10% of patients during their stay have some medication error. There are lots of names that sound alike. Sometimes the error is just in terms of what should have been given with it and wasn't, or it's something they're supposed to be allergic to, but in fact they're not, because that was an old there's all sorts of things around drugs that are just need to be retained within the pharmacy and people who are allowed to prescribe, but I'm just making you aware. And this is just a nice slide about how different things work more quickly or less quickly. So this is one about different types of insulin, and some work more quickly and some work more slowly. This is more about the wrong medicines. There's been a push to make cheaper medicines that you're not paying for the extra packaging for that a company's put on when it's the same drug. But sadly, sometimes that's a cause of errors. And this is a nice slide about the how much drug is available in the body. So with the intravenous thing, you get it straight away and then it circulates and goes down over certain hours. If you take an oral tablet, obviously it takes a little while to work, a bit less of it gets actually into the bloodstream, and then it goes down over some hours. But obviously there are dangers of intravenous because you could introduce infection. It's much more expensive, there's more plastic involved, you need trained nurses to deliver it, the person might not be able to do it at home. There's all sorts of issues, but it's that kind of concept that I just wanted you to have. And then some drugs your body can't get rid of fast enough. So the particular ones you have to take levels of are vancomycin and gentamicin, and these are two antibiotics. And the problem with them, they're really good antibiotics. The problem with them is they can damage your kidneys and damage your ears. So nephrotoxic and ototoxic. So we often take levels, trough levels, like when it's at its lowest, and then peak levels when it should be at its highest. So that's where it's quite critical when you're taking levels to see, to know when the last dose of drug was given and when the next dose is intended, so that you know what level you're taking. That's why you can think of the dip, and you don't want someone to get up to the level where it's causing their body some damage, but equally you don't want to be giving them too low a dose if they are capable of getting rid of it. And polypharmacy is when people are taking too many tablets. So World Health Organization says 4 or more, which is, to be honest, huge numbers of our population, as you know, are on. NHS Scotland uses 10. So it's not actually been defined. But what we need to do is really every medicine has, is it interacting with another? Is it really needed? I'm an orthopaedic surgeon. I would send everybody out for a walk every day, get some fresh air, apple a day, that kind of thing. And some people have a much more, patients are kind of expecting medication almost, but some people are there's over-prescribing, should we say. And there's an initiative called de-prescribing, but it takes a lot of effort, and there are some really good pharmacists involved in this about withdrawing medicines. What's really needed, what's actually going to make a difference. A large number of medications are taken to prevent something that might never happen, but equally you don't want something to happen and then you turn back the time and wish you could have given them that thing. So it's quite a balance, but I'm hoping we've swung away from the huge numbers of medications, and then people have to take it on an empty stomach so they don't get out, they don't go out and do something because they're worried, and or it makes them feel dizzy when they stand up so they don't go out and do something nice. So yeah. Okay, moving on to the fun stuff, making every contact count. And this is about what health's really about, and trying to get people to talk to patients in a way that, so we're all on the same thing. So it's about making behaviour changes. So the principal ones are nutrition, exercise, smoking, and there's some other stuff about getting a good night's sleep, drinking enough water, not drinking so much alcohol. But it's about everybody, all NHS staff doing it. And the critical thing, I like this Making Every Contact Count course, and if you go on to e-learning for health, that's www.e-lh.org.uk, you can get those, you can learn, even not a registered practitioner, the doctor's assistants can learn, porters can learn, secretaries can learn, everybody who's there for patient care, about how to have that conversation. Because it's not about telling people what to do, it's about listening when they talk, when people are talking. So you raise the subject, or they might say, oh, is it okay if I go out for a smoke? And you go, I'm really sorry, there isn't time before your operation, or something. And then they go, oh, well, I suppose I should give up anyway, whatever. It's that kind of, oh, well, yeah, that's quite a good thing, isn't it? But it's getting them to say what they would do. So what you want is to listen out and to kind of amplify when they say, oh, I've got this reason for changing, or you know, that they can do it, or things that motivate them to change, and acknowledging they need to change. All that stuff is change talk. It's listen out for that and try and amplify it. And then the sustained talk where they go, oh, well, I'm just too busy, it's too much, I've got too much going on, blah, blah, blah. That reasons for saying the same needs to be acknowledged, but not, you almost know to just acknowledge but not engage with that bit, so you can amplify the change talk. So it's a bit like you don't want to be lecturing. Stop, that's very bad for you. There's the doctor, architect doctor. What you want is to pick up the bit from the patient going, yeah, when I'm ready. Sometimes lots of people aren't ready, and but it's just sowing the seeds. Sometimes it takes 4 attempts, sometimes whatever. But we want all NHS staff to be part of the solution. So this is a double-sided reflection. So someone's saying, doesn't seem like the right time right now, but at the same time you're worried about the effect it's having on your baby. Just what do you think you could do? So it's open-ended, not a nag, just an awareness and picking up the individual's own change talk. Now a bit about the apprenticeship. And just to say, the Health Education England paid for the first 6 months of the Doctor's Assistant project. Their grant of £80,000 paid for 5 salaries plus overtime plus the laptops plus on costs, which is national insurance and pension contribution from the employer, for 6 months. And it's now an in-house programme. Obviously the salary is paid for by the trust. For managers, they need to know that the apprenticeship requires 20% of time spent training. Now, some of that's in the workplace, like reflection on work or having a meeting, but there's no backfill for coming to educational sessions. But it is so worth it for the managers to make the organisation better, to make the individual better. And what we want as managers to identify an educational supervisor, so a doctor or senior clinician who can help with the individual. The apprenticeship fee itself is paid for by the Trust Apprenticeship Levy. But it allows staff to develop the role and take on new challenges, and I think it will help with staff retention, because it's a really good thing to do, to feel like you're developing, and this is benefits the organisation, well-trained staff, staff will challenge, and for the apprentice it actually makes the job more interesting, because you can challenge other staff. It's like, oh, why are you sending that person for a scan? I heard that all was needed was this blood test when we were talking about in teaching. It kind of makes a bit more challenge in a nice way. If you're you're not kind of shutting down a conversation, you're opening it up, and it does make people ready to apply for other roles. And obviously we don't want to lose staff, but it's so lovely when people go on to something that they want to do. So do a foundation degree or a level 4 apprenticeship afterwards. It opens the doors to that way of studying, and makes you ready for applying for these other roles. Any curriculum is knowledge, skills and attitudes, and we've really tried to put the trust values into the whole programme, and about respect and reducing bullying in the NHS and that kind of thing, about respect for every individual. I've frequently, when I talk to other organisations, had to explain that the doctor's assistant is a band 3 role. It's not, people get confused with physician associates, that's kind of band 6, 7 type of role, but different things are needed for different workforces, and the apprenticeship, this is the apprenticeship level, it's not the banding, it's the level of the apprenticeship. The apprenticeship for the doctor's assistants is a level 3, which is equivalent to 2 A levels. It counts as an advanced apprenticeship. And it's part of the Senior Healthcare Support Worker Apprenticeship, so it's a nationally recognised apprenticeship, and we've tacked it on to the Adult Nursing Support one using a lot of their modules, but with different flavour, because it's assisting on the medical model, a medical way of doing things, which is, as I said, very different from the way the nurses and the physios and so forth do it. So this is slides from the company that's going to be running the apprenticeship, and I probably haven't emphasised that enough, that the way doctors function is different from the way that nurses and physios and so forth function, because if a nurse does something that is slightly off a protocol, they get criticised, and they are not so well backed up by their regulator. Whereas if a doctor does something that's slightly off the protocol, it is sometimes taken at, well, with your clinical judgment, you've considered all the possibilities for this patient, and you therefore made an active decision to do this, whereas other people might do this, and it's kind of what's, you know, a reasonable body of other doctors would have done the same. The General Medical Council works like that. So doctors are much more varied. We go off-piste much more often, and it's more allowed. So it's a very different way of working, and that's why the apprenticeship is different and new. So it's built on the agreement, you know, the employer agrees to release the apprentice for these things, the apprentice is motivated to learn, and the training provider provides what is required. This particular one is amazing because it does roll on roll throughout the year, so we're not trying to get a cohort of people ready for September. A lot is done remotely, there's information, advice and guidance, and there is a coach provided for each person. There's an initial assessment to see where people are at, and it might be possible to get through apprenticeship more quickly. So there's an application process, and that the eligibility check and the assessment is really about trying to work out which models then have to be done, or how much, how it will progress over the next maximum 18 months. On programme, there's a standard eligibility checks and so forth, but maths and English at functional skills are required for the apprenticeship and the care certificate. And there's an assessment at the end. There'll be practice at the end, and to confirm people are ready, and it might be observation in the area, some multiple choice questions, and a reflective journal of what's been done. So that's the package. And then at completion it gets a certificate, and it's a nationally recognised certificate, and 20% of the time should be spent in off-the-job training, but that's anything that's new learning, that is not kind of 100% of the patient care. It's partly kind of working through things. So these are some ideas such as independent research, shadowing, writing something up, having conversation, an educational conversation, coaching sessions, that kind of thing. Some of the mandatory update training can count towards it. But continual progress is required, and a coach is given, and I think it's fantastic because they've got some very experienced coach in this organisation, a dynamic training, and so that they work with you one-to-one to make sure you're on the right path, that you're suggesting things, and that kind of thing, which I think is really, really helpful. And each apprentice is required to complete their work, attend training sessions, and communicate clearly. And locally, there's been a decision that people have to have their functional skills, maths and English, that's GCSE grade A to C or level 4 to 9 or equivalent, before embarking on the apprenticeship, and they need the care certificate. So that's the new rules, that's what's required, and the education department will help with getting functional skills. There's a process. My top tip is there's an assessment at the beginning, so really concentrate. Don't do it when you've just been done a night shift or something. Concentrate so that you can get the best you can get on that, and then you don't need to do quite such a long training session for the functional skills. Everyone gets a coach during the apprenticeship. The department ideally would find a supervisor who's a doctor or senior clinician within the department to help, so you can have a bit of a chat with from time to time. And there will be a training grant available. We just haven't finalised the amount. It's just a few £100. Will be available to help with the extra costs, such as getting memory sticks or upgrading your Wi-Fi or a bit of travel here and there. We know, there is some out-of-pocket expenses, so it's to cover that kind of thing. There was some other slides, so I'm just going to fly through these. Venous thromboembolism. It's a balance between clotting and bleeding, the clotting factors and things that dissolve blood clots. They often form in the legs in veins. You can treat them with mechanical things such as stockings or squeezing things, or with drugs, either oral or injections, or others. The warfarin is the one that needs regular monitoring with INRs. There is a danger of too much bleeding. There's a danger of bruising, interacting with other medications. This is the slide I was looking for about international normalized ratio, and I think I've explained this already. The normal is 1, so you want people on warfarin to target whatever they will have a target, and they have to have a measurement every so often to see whether to take more warfarin or less warfarin. Now, I put this slide up in lots of talks about what's the most dangerous activity you can do. That's dislocated finger joint, and then I stop and wait for people to tell me paragliding or something, and it's not. The most dangerous activity is sitting down, and most ill health is actually the socioeconomic factors cause it, or sedentary lifestyle, sitting down, or smoking. Those are the commonest causes altogether. Genetics is only responsible for 20% of ill health, including 10% of cancers. And bad luck varies. Obviously, everyone has bad luck, but if we could tackle some of the other determinants of health, we'd have a much more healthy population. This is from the Marmot Review in 2010, and this is by deprivation, so it's by postcode, and you're 2.5 times more likely to get heart disease, and also 2.5 times more likely to get cancer in certain postcodes than in other postcodes. So it's a dose-dependent curve, it's an effect, and this is just not fair. And we need to do something about, as I said, the big things are nutrition, exercise, smoking. Those are the big things. And it's difficult, obviously, if people are on low income to get good food, but it is worth doing something because changes are really, really possible. Because it's not those things that you think are too difficult to deal with come down to those causes. We're all the same species, those causes in the body. That's why I was so keen on the making every contact count training, that nutrition, smoking, exercise, and pollution, so forth. Those we can do something about. I was lead author for this, Exercise, the Miracle Cure, that came out in 2015, and I thought everyone would read it and think, oh great, everyone needs to do 150 minutes exercise a week. That's fine, let's all do that. But it's about putting in environments that allow it, play parks and so forth, and making it more normal. And there's loads of it. It's not just me, it's loads of other things from other things going, what can we do to get health better? And the problem is each of these conditions ends up adding up. So at age 60, at age 65, half the population have 2 or more medical conditions. They're multimorbid, and that's just not fair. We could reduce so many of those with changes earlier on. 70% of NHS spending is on these long-term conditions, and just to point out, 25% of the English population do no exercise at all, and 47% of older people. And actually they could. Just walking to the post box and back is really good, just walking up and down stairs, that kind of thing. And anyway, this is a bugbear. So I'm just telling you, we had in this document we've got evidence together. People that do exercise at that rate, 30 minutes 5 times a week, reduce their risk of dementia 30%, stroke 30%, bowel cancer 45%. So this is all worth doing, and it would be nice to get more of the population doing this. I've done a little bit of work about unconscious bias, bullying and behaviours, mainly within the Royal College of Surgeons, where I was on the council for 10 years. And so we produced this report about avoiding unconscious bias, and it's basically when you see someone, you instantly make an opinion about them, and that's okay. That's how the human brain works. But what we've got to do is not act on it. We've got to say hello, treat the name badge, look welcoming if it's a new member of staff, rather than being a bit grumpy and stuck in what we were doing at the moment. We've almost got to fake it till we make it, kind of. So be welcoming to new staff and be very clear about what someone's role is, rather than assuming they're doing a bad job because of what they look like or where they come from, or whatever. Being very clear what the job is. And again, I could talk for hours on this, but the problem is people may have different expectations. So sometimes it feels rude to go, well, I want that piece of work back by Friday. Can you do it like that? Can you achieve it in that time? But that's far better than getting to Friday and going, why haven't you done the piece of work? So it's about trying to change things. Again, it's mostly for senior surgeons and doctors, but it's just that awareness to make the people in training actually ask for the deadline sometimes. When there's a problem at work, bad behaviour, this is a slide I've picked from the Vanderbilt program in America. Most people have got no problems at all. Some people, right at the tip of the pyramid, are really do something absolutely extraordinarily bad, and that obviously needs to be escalated and a disciplinary and that kind of thing. But there's a lot of people that just do a bit of bad behaviour, or they say something that's a bit wrong or a bit rude, and you don't want to escalate all of that, or you might want to, that's fair enough, but there are some things that you need to stop it in the moment, and then someone else have a conversation with them afterwards about, over a cup of coffee. Oh, why did you do that? What, are you okay? That was a bit harsh. Kind of conversation later. It's not for you to do as doctor's assistant. I'm just alerting you to what's going around in the hierarchy, as it were. And this is from the Association of Anaesthetists. It's about, if there's something bad going on, make sure that it's declared. Make sure it's kind of, oh, I noticed you're stressed. Is there anything the team can do to help? Or can we get back to the next patient now? Or something, declare, just to stop something that's kind of like a first aid thing. Like, oh, let's get back to the patient. You don't have to cure everything. And somebody later might want to have a conversation with about, oh, actually, we need to talk about that. I'm work at the Centre for Perioperative Care for a half a day a week. And it's about trying to get the whole pathway better so that people don't slip through the net. And it's trying to get GPs, nurses, physios, surgeons, anaesthetists, everyone working together and predicting things that might go wrong. So I could talk for hours about that. cpoc.org.uk, do look it up. And I've worked with Moving Medicine, movingmedicine.ac.uk. It's about trying to get people having conversations to start off being physically active. Like, what could you do to get more? And so you do go on it, or send patients there or other staff. It's really little tips and tricks about how to get people started being a bit more active. I've been quite ill. I've got something called myeloma, which is cancer of the plasma cells. They make abnormal antibodies that are proteins. They float around the body. My kidneys can't get rid of them. They deposit in the heart, and they cross-link. And they say the heart's a bit rigid, so the heart doesn't work very well. So when I started, I had heart failure, and I've now had a stem cell transplant, and I'm doing great. So it's been lovely. Some of you supported me through that. Thank you. And the summary is, we're kind of all trying to get the little things right, but we're not perfect. We need to, sometimes just little things make a difference, and sometimes things aren't worth bothering about if something's not perfect. We're all doing our best. I think that's my summary. And it's the last slide on, this is Eastbourne, and I cycle to work, I cycle everywhere. I wasn't fit enough for stem cell transplant, so I got an electric bike and got out every day to do that. But just to say, when you're driving your car, you're supposed to leave 1.5 metres, so that's me sideways, I'm only a metre and a half tall, overtaking, and that's a lot, and it's in the new highway code. And if there isn't enough room to overtake, don't overtake, because the problem is that might be someone wobbling about trying to get fit and reduce pollution. And these are all the car crashes, these are all the cyclists who've been injured in a car crash over 5 years in Eastbourne, from lots of little near misses that actually were a bit too close. So the little things matter. That's a message. Sorry if that's a bit too personal. And in summary, thank you. Thank you for all the work you do for patients. The NHS is a team. We all need to work together. I've got a website, scarlettmcnally.co.uk, and I'll be putting some of these things on talks on there, and I've got papers on there and things. If you're interested in all the other stuff I mentioned, at Scarlett McNally on Twitter, you'll find out all about the cycle lanes. But we're all a team. We need to be together. We need to get trying to get the best possible patient care. And thank you so much for all your work. And please try the apprenticeship, because I think it's that extra thing to make it interesting and meaningful and move you on with your life, and it's doable, and thank you.